Hi, my name is Alisha, and I will be presenting on the diagnostic yield of CT angiography for acute stroke and transient ischemic attack indications. Despite recent advancements, CT is still the most common and effective stroke detection technology. The most commonly used CT scan types for stroke detection are NCCT, CTA, and CTP. NCCT uses X-rays to visualize bones, tissues, and blood vessels in 2 dimensions. If a physician wants to administer CTA or CTP, this is done in conjunction with NCCT and requires the additional injection of contrast dye. This allows for CTA to visualize blood vessels in 3 dimensions and allows for CTP to provide detailed blood flow information. It is important for physicians to detect and treat strokes as quickly as possible in order to avoid brain damage. To aid with rapid detection, the Canadian Heart and Stroke Foundation has developed diagnostic imaging referral guidelines with the goal of improving the efficiency with which physicians are able to choose between NCCT, CTA, and CTP. However, no studies have demonstrated the diagnostic yield of these scan types. Therefore, our objective was to determine the diagnostic yield of CTA for acute stroke and TIA indications and to compare this yield to that of other scan types. To achieve this goal, standard descriptive statistics and chi-square tests were used to analyze triage and diagnostic imaging reports from stroke and TIA patients presenting to Calgary Adult Hospitals from January to December 2019. From the patient reports available, we gathered patient, hospital, and physician level data. Patients were categorized into the CTA or other scans category based on the specific scans that they received. They were then further subcategorized based on the findings that those scans produced. Significant findings are those specified on the list compiled by Dr. Katie Lynn as findings that are relevant for stroke diagnoses. An example of a significant finding is an arterial occlusion. Incidental findings are those that are noted on the report by the radiologist, however, are not found on the list of significant stroke findings. An example of an incidental finding is a remote infarct. Now, I would like to discuss our results. We found that 45% of patients who received a CTA had a scan which resulted in no abnormalities, compared with 61% of patients who received other scan types. We also found that 23% of patients who received a CTA had a scan which resulted in at least one significant finding, compared with only 9% of patients who received other scan types. Lastly, we found that there was not a significant difference between the percentage of scans resulting in only incidental findings from CTA and other scan types. We believe that incidental findings might pose a risk for overdiagnosis because they're the only findings present for the physician to act on. However, we do not believe that when both significant and incidental findings are present, that this poses a risk for overdiagnosis, since a physician is likely to only act on the significant findings. CTA resulted in a greater number of significant findings, while not increasing the number of scans, resulting in only incidental findings. Therefore, if a physician is going to scan the head already, it makes sense for them to take the extra time to perform a CTA scan as well, because the findings from CTA might be missed if only NCCT is completed, and any incidental findings produced will likely be produced by NCCT anyways. One limitation with this study is that we were unable to access information on the actions that the physicians took based on the scan results, meaning that we do not actually know if overdiagnosis resulted from any of the incidental findings. To conclude, we found that CTA has a higher diagnostic yield compared to other scan types for patients with acute stroke and TIA indications. Using CTA in addition to NCCT for these patients provides more scans with significant stroke findings and fewer scans with no abnormalities, resulting in the benefits outweighing the risks. The results from this study will allow physicians to make more efficient and appropriate scan choices, resulting in improved patient outcomes due to them receiving the right treatment quicker. To further our work, a survey can be conducted asking physicians in the Calgary zone to explain why they choose one type of scan over another, if they tend to act on incidental findings, and how our results might benefit them. I would like to thank Dr. Bijoy K. Menon, Dr. Eddie Lang, Dr. Katie Lynn, and Dr. Sheila Coots for their help on this project, especially Dr. Lynn for compiling the list of significant findings used in the data analysis. I would also like to thank Alberta Health Services for the provision of data and Alberta Innovates for the 2020 summer studentship. Here's a list of my references, and thank you for watching my presentation.